This is like as a PG, just narrating whatever stories we have seen, and I'm sure you guys would have much more to say. So let's hear. I have a lot of
Okay.
questions about pediatrics specifically. Very interested, and it's very new. So
So hello everyone, and today we have Dr. Anaga Menon, who is ophthalmologist, and we have Dr. Darshya Kothari, who is a pediatrician, and myself, Dr. Rohan Nathwani, general surgeon. So today we are here for a discussion that is on diabetes, and we will cover from each of the departments. So going to Dr. Anaga Menon, we can just go ahead with it.
thank you for having me in the session. Today I'll be discussing very basics about diabetic retinopathy and its awareness. Basically, my aim here is to spread awareness. So as we all know from MBBS first only, we have heard that India is the diabetic capital of the world. But people, the general public, they are only aware about random blood sugar, HbA1c, and all those things. But they don't know, apart from the general narrow perspective, they don't know which other parts of the body can be affected and how and what approaches they can do to prevent it. So today I will talk about how a layman who has diabetes should, approach the ophthalmologist. So usually diabetic retinopathy is a disease of the microvasculature of the retina. So as we already know, there are two organs in the body that have end arterial circulation. That one is eyes, second is kidneys. So it is because of this end artery microvascular circulation that the diabetes, that is the advanced glycation end products. Okay, I'm not going to go into all detailed, terms.
Yeah.
There is something called advanced glycation end products, reactive oxygen species. These two will go and damage the capillaries in the eyes as well as in the kidneys. And that is why we see most of the changes that are related to diabetic retinopathy in the eyes and in the kidneys. And of course, not to forget the nervous system as well. Okay. Peripheral neuropathies can also be a very classic feature of your diabetes mellitus. Now, India is, or let us say Southeast Asia, by 2040, statistics approximate almost 75% of Southeast Asians to be affected by type 2 diabetes mellitus. So that is why it's very important for us to have, as doctors, a very basic awareness about how we should treat our patient as a whole and not just to treat your specialty. So from opthal perspective, there are many grades of diabetic retinopathy. There is early diabetic retinopathy, and in that, after that, we have mild, moderate, and severe, very severe, and proliferative diabetic retinopathies. So these are just gradings based on the severity of the fundus photograph, that is the retina photograph that we see in the clinic. Okay, so this again, as I have mentioned, the reactive oxygen species, advanced glycation end products, these all will have effect on the capillaries. Capillaries, that is the end branches of the arteries, that will damage it. And what happens is that there is a covering around these capillaries. These are called pericytes. So the very characteristic feature of our diabetic retinopathy is the loss of pericytes around these blood vessels. When the pericytes are gone, there is like a bulging that is formed around the capillaries, and that is what we refer to as microaneurysms. This is the first stage and the first thing that we should actually be visualize when we are doing our fundus imaging in our indirect ophthalmoscope. Okay, so this is the first thing. And if any patient has microaneurysms, we must call them up for a yearly follow-up. Now, again, this is broadly categorized into whether the patient has a type 1 or type 2 diabetes mellitus. Type 1 diabetes mellitus, at least from 5 years from the starting of the diagnosis, they should start visiting their concerned ophthalmologist or even better retina specialist for evaluation. For patients who have a type 2 diabetes mellitus, it is good to get an annual checkup of the retina because for different patients, based upon their glucose control or other associated risk factors like hyperlipidemia, blood pressure, okay, sedentary lifestyle. And as we all know, the dictum smoking and alcohol contributes and increases the risk of everything by many fold. So patients who have this risk factor based on that, the progression of diabetic retinopathy will be different. Some patients might progress very slowly. Some patients might progress rapidly.
I just want to ask you
Yeah.
one thing. How will you know that a person
Yes.
has a retinopathy? How will the patient know that he's going towards retinopathy or is having vision problems due to diabetes only
Yes.
and not due to myopia or
Correct.
hypermetropia?
Correct. So it's very imperative that the patient gets a general checkup, especially after the age of 40. Every 6 months, he gets a general checkup by the primary healthcare provider. And even as we know, the elders in our family, we always ask them to get a basic blood test done, like random blood sugars, okay, glycated hemoglobin, and such. So, in those parameters, if we say that this patient is pre-diabetic, okay, based on the blood glucose levels or HbA1c, or if this patient has a family history of diabetes, it is the primary healthcare provider's role basically to refer the patient to an ophthalmologist or a senior specialist so that they can undergo a screening. So that is the main thing. But apart from that, some patients, unfortunately, they might be knowing that they have diabetes, but very late in life, they will be developing certain symptoms like floaters, dark spots in the visual fields, and generalized loss in vision. Let us say a layman won't be able to describe black spots in the vision. He will say he is
Mm.
seeing less. So these symptoms must be taken into account very seriously by whoever is the treating physician, and be it any forms of medicine, because there are a lot of systems of medicine in our country uh, apart from allopathy. So this video should go out to those other alternative forms of medical healthcare providers also, because whatever happens in the retina has to be intervened by the retina specialist only. And if those healthcare providers also, without feeling biased, refer the patients to the diabetes clinic for the retina and other general checkups, then actually the burden of diabetes, and from my perspective, the ocular burden of diabetes would actually be cut short to a great extent. And also, Dr. Rohan, I would like to add upon this to my answer. There are a lot of, especially even people in our family, no matter how educated they are, the first question is, any drops will be available for this problem? Even for cataract, we hear it
Mm.
as a junior PG also. Any drops for this cataract or any drops for this diabetes? Sorry, diabetic retinopathy. But the answer is no, drops do not go inside the eye. Okay, you need a retina specialist to evaluate and more important, more than treating, to prevent and slow down the progression. So this is the main thing about diabetic retinopathy that I would like to highlight. Awareness.
I want to ask
Yes.
one question.
Yes.
Uh, how common is diabetic retinopathy incidence in pediatric age group?
Actually, in pediatric age group, we have seen type 1 diabetes to have a very fulminant picture, because type 1 diabetes, as you know, is very difficult to control also. So
Yeah.
although the number of patients that come to us for referral is not much, we have seen, at least in my 3 years of PG, one or two cases of diabetic retinopathy in pediatric cases. But thankfully, they only had hemorrhages in the periphery of the retina. They did not have any hemorrhages or anything affecting the center of the retina, where we again classify in diabetic retinopathy as
Mm.
center involving and non-center involving. Center involving means, as we all know as medicos, in the macula has the maximum concentration of your photoreceptors for color vision. So if the fluid gets accumulated there, that is when the vision is really going to drop. So thankfully, the
Yes.
cases that we have seen in pediatric uh, type 1 diabetes had only microaneurysms and dot blot hemorrhages, which are the early stages. But
Okay.
again, there are other cases which wherein we have seen vitreous in dengue cases in pediatrics. So that is also like a really important topic. Again, if the bleeding does not resolve, we must refer the child to a vitreoretinal surgeon so that they can carry out the appropriate procedure, which is basically called a vitrectomy, wherein you replace the gel inside the eye and
Yeah.
fill it with a gas or some other substitute, like a gel or something.
Okay. Thank you.
Yes, no problem.
So I think it's
So, any other questions?
yeah. No, it's done, I guess.
Already you are so
Okay.
informative.
No.
Hmm.
This is like as a PG, no, just narrating whatever stories we have seen, and I'm sure you guys would have much more to say. So let's hear. I have a lot of
Okay.
questions about pediatrics specifically. Very interested and it's very new. So,
So, okay, we can go towards
okay.
surgery part from here. So, as we all know, in surgery, the most common in case of diabetes, a patient comes for a diabetic checkup. Here, they don't come for diabetic checkup, they actually come for a diabetic foot. And what are the sequence of changes in diabetic foot that we have to know? And firstly, it's a very much preventable cause. In diabetes, a patient coming with diabetic foot is very much preventable and it's cured also. And otherwise, in very late stage, it can go to amputation. So as we all know, there can be three things in diabetic mellitus to diabetic foot. That is, as we all know, it is neuropathy, ischemia, and infection. And it's a sequence. It will go simultaneously. So whenever a patient comes to us, first of all, we check for if there is an ulceration or the neuropathy or it is infected or abscess formation is there. So if you have a chronic hyperglycemia, so it can lead to nerve ischemia, which will again lead to neuropathy. And we can have three types of neuropathy in case of diabetes. We can have a sensory neuropathy. As we all know, it's the senses will be lost. The patient won't be able to feel the motor, the minor traumas, burns, or foreign bodies in the footwears. Other, we have the motor neuropathy, which is basically due to the muscle wasting, which will be there. So it can lead to hamartose, clawtose, and prominent metatarsal defects will be there. And thirdly, we have the autonomic neuropathy, which will lead to loss of sweating, cracked skin, and again infection will be there. So moving ahead, first there will be a callus formation. So what is a callus? Callus is a hardening of the skin. So first, after neuropathy, it will lead to callus formation, which will again lead to ulceration due to repeated traumas. So, and in case of infection, what it is, it can go to cellulitis, abscess, osteomyelitis, all the complications for this. Then coming to the ischemia, it can lead to poor healing, gangrene formation, and as we all know, in case of gangrene formation, we have to amputate the patient. It can be both dry as well as a wet gangrene. So in case of dry gangrene and wet gangrene, you all know the difference. Mainly the difference is there is a well demarcation in case of dry. There is no line of demarcation in case of wet gangrene, and more foul smelling and infection will be there in case of wet gangrene. So finally, if the diabetes is not controlled, it can go to sepsis, and patient has to be admitted in the ICU at first and control all the diabetes, the vitals, and lastly, it can lead to multi-organ failure. As already Anaga said, it can go to kidney, ophthalmopathy, retinopathy, it can go. So it's a multi-organ, basically diabetes is a multi-organ thing. So it can lead to that thing. So in case of diabetes foot, we have to amputate it. If it's not controlled initially, you have to amputate it. There are two types of amputation. As we all know, there can be minor amputation or a major amputation. Major it is above knee and below knee. And in minor, we have the toe, tarsal, metatarsal joints, we have to remove it. So at last, what the thing is, it starts with a neuropathy, then it's ulceration, then ischemia, it worsens the progression of the disease, and at last, it's mainly the glycemic control has to be remembered, foot care. So whenever patient comes, we tell them to have a soft foot care and to remember if there is a prick or any trauma to the leg. And early intervention is the best thing. So again, that much is enough for surgery point of view, I think. Any questions if you have? I don't think it's yeah. So we can go ahead with the
So
pediatric part.
I had one
Yes.
question.
Yeah.
So, like, I really feel like, okay, when I was in intern, when we were in surgery, actually, surgery is one of the departments that really fascinated me. And it's
Thank
a
you.
real miracle, like, how one
Yes.
question. So,
Yeah.
like, I really feel like, okay, when I was in intern, when we were in surgery, actually, surgery is one of the departments that really fascinated me. And it's
Thank
a
you.
real miracle, like, how you guys, like, the amputation part, especially
Yeah.
the how you like cut off basically an appendage of the body by preserving and preventing extra bleeding and the how actually I always had this doubt. So let us say you cut off an appendage and you suture the end. So like the blood circulation, how does it it come back, like the arteries, veins? Do you guys suture the arteries and veins also, like the
No, we have
anastomosis,
to
or
suppose if
uh,
we have to do below knee or above knee amputation. So we preserve suppose if we are doing below knee amputation, so we preserve the artery of the above knee part. So below knee already the artery
okay.
supply is lost and already the part is also lost. There is no use of that artery. And we have the collateral supply also is there. The collaterals will develop after amputation. So there is nothing. More importantly, after amputation, what the patient complains is that he already has a leg. That's a psychological thing. For around 1 month, the patient will feel that he already has a leg, but there is no leg in that case. So that is the thing. Anything else?
One more question from my side. Um, Basically, from the start of diabetes in anyone in our family member or the new ones, how early will you prescribe him to wear that diabetic chappals and whatever is there to prevent the ongoing ulcers? How early he should start?
See, for us, the patient comes in a very chronic stage only. Patient won't wear chappals and all that. So whenever the patient comes, whenever we see a patient having anything, skin changes or callus formation, is there anything from the leg, in the leg or in the hands, wherever. So in the legs, we prescribe them to wear chappals and the thing. From the starting also, we can't do it, but the patient don't come, and patient won't listen to you. That's the thing. So they are in the chronic stage only when they appear with the foot changes or infection, whatever you
That's
can
what
say.
we should be doing this as a change. We should
Yeah.
be telling them to wear as
From
early
the
as possible.
as early as
Yeah,
possible
The
yeah.
because
problem is, I think, affordability, no? These rural the people, first of all,
Actually,
they
the
just come.
government also has the scheme of providing sandals, diabetic
Okay,
sandals.
that's good.
Yeah,
That's good.
yeah.
basically the thing is when the neuropathy develops, it's around 5 to 10 years. It develops in 5 to 10 years. So you can tell the patient after 5 to 10 years also from development of the diabetes to wear the chappals. Okay. So any more questions? Mm,
I think, yeah, I mean, from my
no,
part,
I guess.
yeah, that's
So
it.
we can go towards the pediatric part right now.
Sure.
So yeah, Dr. Darshita, you can continue.
I'm here to educate everyone about the basics about the diabetes. As we all know that it is very hard to accept that their small children's getting diabetes, but it's very like it's a better thing to accept that yeah they can also get a diabetes, and even the neonates less than 6 months present with diabetes. So we'll but just will educate everyone here with the cause of the diabetes so that everyone knows, because the parents come to us to ask why are our baby getting diabetes, our family members are not suffering, there's no family history, they don't eat junk foods, then why are they developing? So first of all, the most common type of diabetes in pediatrics is type 1. The type 2 is also there, and there is Modi. Modi is called as a maturity onset of diabetes in young. And the fourth one is mitochondrial resistance. Fifth one is we have genetic monogenic forms. Sixth one we have neonatal form. So neonatal form, monogenic forms, all these will be having genetic defects. Like some of the potassium channels will be defective. Some HNF1A, 14A, these kind of genes are there, they will be defective. But we should be understanding the basic ones which are we all are dealing with. The first one is diabetes type 1. So the age of onset will be 6 months to 18 years any time around. And if they are presenting with type 2, they can present around the pubertal age group. And Modi presents less than 25 years of age. So what is happening in type 1 is the beta cell has been destructing, so there's a decrease in the release of the insulin, and unfortunately a stage comes where there's an insulin which is vanishing from the body, and there's a compensatory hyperinsulinemia. And even the stress which they are ongoing, the growth hormone which is releasing at the night when they are sleeping, as well as the stress which they are suffering day by day basis, which will be releasing the stress hormones like cortisol and glucagon. So all these things what they are doing is basically they are causing the lipolysis, and they are creating free fatty acid in the peripheral tissue. And what is happening, there's a lot of burden in free fatty acid in our body. And second of it, there is glucagon which is always present in our body. So that glucagon will not allow this free fatty acid to convert to ketones. Sorry, to utilize by our adipose tissue, and this will be shunting process will be happening, and free fatty acid will not be utilized. It will be going to ketone formation. So now we know that ketone bodies are forming in this children's. We also know there's a loss of lot of glucose which is there in their body. Why? Because insulin is not there. And third of it, due to high glucose, there is a high osmolar load, means our osmolality is already increased. So because of it, there is a osmotic diuresis. So what I mean to say, combination of it, this is, why is the child presenting with a lean mass? Why are they losing weight? Because most of the children who present to OPD, they'll come with a complaint of my child is not gaining weight. He's losing weight from past 3 months, 4 months, and he's having excess of urination, polyphagia, polydipsia, what and all we see. But this is the classical symptoms which not every one of them suffer. They have a mix and match of nausea, vomiting, dehydration. They have easy fatigability. They have basically they have loss of weight. They come in a catabolic state. So the reason of this is here, that free fatty acid is being formed, and it is not being utilized by the body, and it is getting shunted towards ketone. And plus there's a osmotic diuresis which is getting all the electrolytes to be lost from the urine, so the child is in cachexic state. So this is about type 1, and type 2 is about the resistance which is at the level of our organs like adipose tissues and skeletal muscles, liver. So the mechanism will be same, but the type 1 children's always land up in diabetic ketoacidosis. There are 80% chances of them landing in ketoacidosis, which is a nightmare for a pediatrician, because if anyone coming with diabetic ketoacidosis, we have lot of things to monitor, lot of things to start with. Like first we have to diagnose it, whether it is a diabetes or not. There are many mimicker of diabetic ketoacidosis. Then we have to see which category are they lying in. If there's only a mild dehydration, if they are not lying in any categories, then we can straight away start with insulin, subcutaneous insulin. But if they have lot of dehydration available, like we have a categories mild, moderate, and severe on the basis of venous blood gas, which we do on the basis of pH and on the basis of bicarb levels, then we can start with the dehydration correction first, and followed by a transition to subcutaneous insulin, which are available in many forms. Like there is a basal bolus regimen, there is a 3 drug regimen, there is a mixed regimen. There are very variety of regimens which are available. So the basic education which I want to spread here is that everyone asking why is my child getting the diabetes is, first we have to know that whether it is type 1, type 2, MODY, or it is a neonatal onset on the basis of age. And yeah, of course, the family inheritance also matters, but not at much instance here. So in type 1, if a sibling is having a diabetes, the other sibling will have 8% chances of having the diabetes. And if a mother is having, then it is a 4%, father is having, then it is a 6%. But at the end, 80% of the cases which we are seeing here is the idiopathic one. So the cause here is either at a gene level, either some children suffer from infections like hand, foot, and mouth disease, which I came across recently. A child was suffering 6 months back with a HFMD, and then after 4 months he started having excess of urination and fatigue, and then unfortunately he was diagnosed with diabetes by HbA1c levels. So the parents here are to be informed that any infection which are causing an autoimmune process inside, Th1 receptors are being activated, can go and harm the beta cells and unfortunately can land up. So there's no hard and fast rule why are they getting. Even the rubella, anytime exposure with rubella syndromes can also go with this. Then third one is autoimmunity. There are a lot of patients coming nowadays with autoimmunity. So we have to be very vigilant in OPD for seeing any autoimmune markers if we can, like vitiligos or any celiac disease, because the children nowadays are complaining of abdominal pain on and off. So all the abdominal pain are not due to mesenteric lymph nodes or due to functional constipation. Some chronic pain have to be like not missed, We have to detail investigate about it, because incidentally we come about celiac disease, which is an autoimmune disease and has a very strong association with type 1 diabetes. So recently I've come in my ward with a patient who had 4 months back hand, foot, and mouth disease, landed up in diabetes associated with celiac, and symptoms are only vague pain, abdomen pain. So this is about treatment and management. I will just want to tell that diabetes is very complicated, and it's like the parents have to be psychologically strong. Diabetes as well, diabetes specialist, pediatrician, and dietitian. Three play a very good role in educating the parents and the children, because it's a very new thing for a parent to start giving subcutaneous injections, and that too we have to educate them in a proper way about the monitoring of glucose around the clock. How many times should they monitor the glucose, and what meals should be given to the children, because anyways they are not the adult who will listen to you and will agree for not eating candies, not eating chocolates. We have to prepare some kind of candies in the home which are of less refined sugars. We have to introduce some food like nuts, lean meat, chicken, eggs, and otherwise, if someone is vegetarian, we can tell them of avoiding rice, and we can tell them of introducing bajra, ragi, and jowar as in the form of dosa or in the form of chapatis. But wheat has to be avoided, rice has to be avoided. Too much fruit, sucrose containing fruits like we have grapes, banana, and papaya. All these things have to be avoided, but yeah, they can take in the form of 4 to 5 cubes a day. So this is all about, and the latest thing which I want to share is nowadays there are continuous glucose monitoring system and a closed loop system which has come in the market. So this is like not everyone can afford. It's not in the middle class which can afford this, but it is a new thing which I want to share. Is like it's a pump kind of thing which is placed in the waist of a baby or a child, and he continuous monitoring of the glucose is being there. There's no pricking thing which is happening every time we have to do from the lancet. So the advantage of it is, yeah, it is causing us to take the blood glucose level round the clock. At the same time, the prick which we have to do will be less. We have to only monitor 2 times by pricking the finger. Otherwise, it also has a sensor and alarm, which will be alarming when there's a hypoglycemia, sudden hypoglycemia, or if there's an overdose of subcutaneous insulin which was taken, or if the child is starving, because the children will go and play in the ground and they won't eat. So that time also they will have hypoglycemia. So that is all about my part, and
So I just want
just
to ask
want to
one
tell.
thing. Yeah,
Yeah, yeah,
I just want to ask one thing. What is the preferred site? In case of insulin, if you are giving insulin in adults,
yeah.
you're given delta or food or whatever. What is the preferred site in case of pediatric group for giving
The
insulin?
best accessible part is always the abdomen and the thigh, uh, because it is a accessible one, and the second thing is lot of bulk is there, so even the
Hmm.
child can be trained easily. But yeah, we have to take care of one thing is we have to make it a rotatory method. We have to train them that don't give the insulin again and again at the same site. Keep on rotating in a clockwise or anti-clockwise pattern in and around the umbilicus.
And secondly, what I was just thinking of is if the patient develops a decay in case of pediatric. So what is a
Yeah,
dangerous complication? As in adults, we see hypokalemia and then arrhythmias. But in pediatric group,
yeah.
what is the dangerous complication you have to encounter
The dangerous complication which we often come, it's very
in
sad to
decay?
say, but we often come across is cerebral edema. Because the thing is, we are to be very much vigilant during the first hour of the decay management. Many people are very much fast and they start with the insulin at the first hour, but it is a myth. We have to correct the dehydration, the underlying dehydration which is there. Because as I said in my previous statement, that diabetes is all about osmotic diuresis, which is causing our electrolytes to go from the urine. So obviously potassium is being lost. That is one part. The second part is we have to take care of potassium in the fluid. Second part is there's a lot of dehydration which is lying inside. So we have to first correct the dehydration in the first hour. We have to give bolus according to the category of dehydration, and then we have to switch to insulin infusion when the ketones are negative in the blood. Then we can switch over to subcutaneous insulin. So cerebral edema, we have to be very vigilant. We have to keep on seeing if any seizures, if any bradypnea, if any irregular respiratory pattern, headache, or any lethargy during the treatment. So we have to be very vigilant about it.
And thirdly, one more thing I was just thinking of is suppose a patient is having poorly controlled diabetes. So what will be the complication?
Yeah.
First complication the pediatrician will find in a patient with uncontrolled diabetes.
Yeah, uncontrolled diabetes will always be fatigued and lethargic. It will always go for diabetic ketoacidosis. The uncontrolled diabetes in pediatrics will never be silent. It will always be overt, and they'll come with nausea, vomiting, dehydrations, and can land up in cerebral edema without going to ketoacidosis also.
Yeah, that's all from my side. Anything you want to ask? Uh,
Yeah, I was actually I wish we had PGs like this in our pediatrics department because I just felt like really I got a really very clear walkthrough as if I got to be like a resident for a day. I kind of got like a nice walkthrough about pediatric diabetes. And I was actually, as I told you before, Rohan, I was actually looking forward to this pediatric side because nobody knows about it. Everybody thinks diabetes is something that happens after 40.
Yeah.
It's like a new light, and I'm glad that Dr. Darshita has put so much light upon the topic and so many more topics that are related to pediatrics. I would like to hear from Dr. Darshita. So that was
Thank you.
yeah, it was a really well done session. And definitely Rohan though is already in the Instagram business. So I have seen his Instagram posts also, and kind of it's a good refresher for surgery as well.
Yeah.
So yeah.
so yeah, so we can end up this session, I guess. So thank you everyone for joining. Thank you. Have a
Okay.
nice-
Okay, thank
Thank
you.
you.
Yeah.
Thank you so
Thank you.
much.